Welcome back, everybody. This is the Prehospital Paradigm Podcast. I'm Scott Wildenheim. Got our usual crew with us today. We got Dr. John Hill and firefighter paramedic Caleb Ferroni, and our special guest today, John with no H, John Cameron from our. I really want you to help kind of explain this. We call you our data team, and this is but. We know you exist because you're so part and paramount to everything that we do as EMS administration and delivery with delivery of care and charting and stuff. But I don't know if everybody out in the world really knows what the back end looks like and how much stuff you guys support and who else helps you out.
So in general, we have a 3-person team: myself, Mike Monahan, and David Yash. The three of us kind of make up what we call our data reporting team for University Hospitals EMS Institute. The whole idea is that we position ourselves as kind of liaisons between all the fire departments and agencies that University Hospitals provides medical control to and any of their technological needs. So most of that being under documentation. That's how we originally started with this program, was really trying to help facilitate better documentation using software and hardware tools to get good documentation for all of our agencies under the medical control. So that's kind of branched off into, we'll help you with set up your life packs. We'll help you set up any of your Verizon stuff, whatever. We're trying to help in any way we can, but our main focus is really that documentation component.
Yeah, and certainly we use all that data on the back end to influence decisions about, it might be as simple as, do we keep a medication on the truck, or, is this therapy working? There's huge implications, and of course the bigger a pool of data that we have to pull from, better information you're getting. So as that's ballooned, and today's topics and the things we want to really hammer today is really about charting and documentation. Probably everybody's least favorite topic, but
my favorite.
Yeah, it's your favorite topic. But I'm sure people that are watching or listening are kind of cringing, like, more documentation BS. But it's so impactful to so many different things, and that's kind of what we want to talk about today. And if we have time later, then we'll get into maybe some other communications things that we certainly, that tie in with communication and documentation. So like the patient handoff report and really that patient, that patient report over the radio, over the phone, basically this day and age. Of course, it's mostly a phone. So in your statement that, you've kind of got your fingers in all of these things in the EMS digital world. What we really want to focus on today is health EMS, and that makes up the bulk of what we UH supports. We know there's a few other charting systems out there, but really as those depreciate over time and as we focus on the health EMS product alone, that's really what that's the bulk of our data. And what are we talking about from percentage-wise, how much of the system is?
So we have about somewhere between 175 and 185 agencies currently using Sansio Health EMS as their documentation platform. Most that's being done on University Hospital supplied iPads, but it can be used all kinds of different platforms you can use that software on. So in total, I think this year we're going to put about 325,000 PCRs, individual PCRs, through the system under UH, which puts us at a very large scale. So that is a lot of data to collect from. So when you talk about driving clinical or treatment plans, or what meds are in the box or what meds we're going to get rid of, we're using that data to make those decisions. And that's a huge help to the Institute overall when you're looking at that size of a data pool.
And that gives us some pull with them, too. I guess I want to talk a little bit about that. They probably don't want us talking about that. But, such a large user, certainly in our conversations and our administrative roles, we've gotten some stuff done to better the product on behalf of UH.
Absolutely. Yeah. They do consider us a partner as much as FD&Y is a partner of theirs. That FD&Y has, they put quite a few PCRs to their system also, but we, at 325,000, it puts us right up in that same type of echelon. We are considered one of their keystone customers, and they work with us very closely on a daily basis. Pretty much we are passing ideas back and forth to help improve the product. So it's a really good partnership between University Hospitals and Sansio.
And I know I've told my story to other, other people in our sphere of influence, if you will, but for the greater audience. I've personally deployed three different EPR systems with my agency over the years, and this by far has been the easiest, and it's not without hiccups. Nothing is. I mean, but
it's user friendly.
It is, and
definitely getting better. I mean, like everything, like you said, you're tweaking it constantly, and I think it's nice that individual fire departments have a little bit of their own power per se to tweak it the way they want it to work with power fields and such, and it won't let you advance the chart without doing some of those, and that's kind of nice too.
Yeah.
Before I get into the whole why stuff, you hit a point there that certainly strikes a chord with me, and that is taking ownership of. You give them a kind of a basilar product, kind of a minimum expectation of what we need. They can do other stuff with that, right?
Yeah, we set up the software to be, this is kind of like the UH standard, right? These are our expectations, not only from a data reporting standpoint to what we send down to the state of Ohio, right? They have their standards. And then we also layer on top of that our own UH standards for what we consider is going to be important when it comes to documentation and your clinical presentation or clinical documentation of that patient. Those are UH standards. And then on top of that, if you want, as an agency, want to add additional fields, you have particular reporting that's important to you. Let's say you service more than one small area, you need to separate the responses out to other areas near you. We can help you set up that kind of documentation. So there's a lot of configurations inside the software that we can help you set up with. So if you have those needs, reach out to myself, reach out to any of my team. We'll help you do
Monahan
that.
or Yash, yeah. I know I've had situations where you're trained and we're coached as providers to ask these questions or whatever on. See, let's just take OB, for example. I mean, there's a pretty exhaustive list of things you're supposed to remember to ask on an OB call. And, I was seeing that those basic questions that we should be asking weren't getting answered. So in my house, I made a power field for OB questionnaire. And literally, I mean, the provider can just bang, 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 go down that list and make sure that we're getting, quality information about the things that maybe we forget about. Right?
And it helps keep you on track, especially when we go to OB calls that aren't that frequent. Pediatric calls, if you want to set up a pediatric APGAR or something, and it's right there, it's power field. It's not something we use every day. So when it's reminding you need to complete this, it's right in front of you. It's, why not use the resources? We aren't sitting for National Registry test anymore. We can cheat.
Yep, absolutely. Oh, absolutely. One of the things that those power fields can do is put a label.
Right.
Put a label in there, and I use that for a lot of things, like use an APGAR score or stuff like that. You can just put that right in the chart, so they don't have to go to another piece of reference material. But just going to that flexibility is, let's make sure that the departments also understand that they can have some control and they can help tune this to their particular needs. It doesn't have to be minimum stock, bare bones, do this because we say to do it.
Or even put in their own procedures that they do for something. Like if this call comes up or you're at this facility or this address, this is what you need to do, or this is where a Knox box is at, whatever.
Absolutely.
Yeah, it's a tool. We want everyone to use it to maximize what works for them.
So I kind of got off on that just because you brought that up, and that's always been very important to me personally. But it's, I guess we got to get into the why, right? Everybody knows we have to do the documentation. Is every piece of this? I guess, does everybody understand why it's so important, other than somebody yells at me if I don't do it?
Right. Do they really know how many other people are looking for that documentation? I think that is important to go through the why. So, first off, we always talk about the clinical aspect, right? For us as medical control, that clinical is the most important. So the medical directors, to this point, are expecting to see the chart in your PCR in that patient's medical record. We have set up a really good system in university hospitals as well as our neighboring facilities where that chart is being transmitted electronically. And these physicians, it's not something where it's on a fax machine and they never see it.
Right.
They're expecting to see it. So first off,
we reference it.
Absolutely.
In real time.
So from the clinical side, it is obviously that is our most important thing. Then, unfortunately, from the legal side, this is your document. This is when you write it. I'll tell a personal story here. Hopefully, we'll see where this goes. But when I was a brand new paramedic, I was only on, I was new license maybe 6 months, and I was on an accident in which a semi-truck ran over another vehicle, caused extensive injuries to the patient. I took care of the semi-truck driver. He made a statement very clear to me, essentially admitting guilt. Sure. I quoted that in my PCR. I wrote a very good narrative. I was very proud of it. 3 years later, I've moved states. I've changed professions pretty much, a completely different world. And I am brought in to court via subpoena to testify as to what I wrote in that document. I had for 2 hours, just shy of 2 hours, prosecuting attorney, defense attorney, grill down to every single word I wrote in my narrative. And because I wrote such a good narrative, and I was very proud of the job I did, and I presented the information as factually as possible, I helped that individual who was the victim of that terrible incident to get compensation and get care for, versus had I not included those statements, then I don't know where that would have ended up. So documentation is important. It wasn't just affecting me, it wasn't defending myself or anything I did, but it helped someone else down the road because I made sure that I documented appropriately in that case. So that's kind of like my little personal reason of why documentation is important to me all these years later that I've been doing this.
It's also important to remember that we talk so often about not putting subjective material in your report. In your case, you did on behalf of the patient who spoke those words. And if you quote unquote, you can use subjective information as long as it's on the patient's end, not ours. We can't use our own subjective information.
I mean, it was this was a particular statement that I put in quotations marks because the patient did tell me that, right to my face. So I was 100% certain I knew exactly what he said, and it was something that needed to be included. So,
and that's patient advocacy, and we talk about advocacy. I stress it so often, but you might not have been a patient advocate for the semi-driver, but the patient who really needed it, that was also under your scope of care with your department. I mean, you worked as an advocate.
Yeah. So the legal stuff, obviously, but again, it is your document. So when you have to be deposed, if anybody has ever had that wonderful, wonderful situation, or have ever had to go to court, it could be years later, and there you are. All you have is that piece of paper, or in this case, this electronic document to refer to. So it's super important that you are going to use that tool to then recollect what happened, could be years later, and they could be drilling down on every single word in that. So that's why, for the legal standpoint, it is your document. You write it. You're responsible for it. It is connected to you, and you need to use it as a reference for yourself. Next one would be the operational side. So us, as University Hospitals EMS Institute, we use all this data like we said before. We use it to figure out what meds we're using, what treatments we're using. So the operational side can be really important. Your own agency might use it to determine what resources need to be put where. Even as a hospital system, we might say, hey, look, we need a stroke center in this particular geographic area because we're having these long transport times. So from an operational standpoint, it becomes very, very important to use this documentation also.
I know we often probably don't discuss this, but it's often used to drive our continuing education.
Absolutely.
How many times is something that one of us has caught in a chart has been the impetus for next month's CE, or scheduled CE thereafter, or
if you get that last minute, hey, can you add these 3 slides because something came up?
I was gonna bring up this particular last CE where
pink slips,
where we snuck pink slips in there, and of course it's transparent to the departments out there. But that was the night that CE went out to the masses to be taught. It was like, oh, we need to get this discussion about pink slip, and that wasn't just an arbitrary thing. People were sitting around and be like, I wonder if we should add something to this. It was no,
but
it was
I think the old mentality of thinking,
data.
especially when PCRs were on paper, was that you would never look at them, and that's I think exactly it's what you're saying isn't happening, and I know that to be a fact. That
even if it was on paper, if I had that report in front of me, there's going to be information in there that I need to take care of that patient.
Absolutely.
In the emergency department that doesn't get conveyed during the pre-hospital report or even bedside report. There's probably going to be some information in there, and as we dive into this, it's going to be about blood loss, or what did the scene look like, or how much intrusion into the vehicle, like what happened
all
on
the
scene.
Information you can't possibly get without us being there.
And that's the thing, is I'm not there. I'm in the emergency department waiting for you guys to bring in whatever patient you're going to bring in, I didn't see what's actually on scene. I need that report to paint me in words what actually is going on so I can better understand what happened, as opposed to just, oh, I've got a patient on a backboard or in a C-collar or in cardiac arrest or AFib with RV or whatever. What was happening on scene that got us to this position?
Absolutely.
Furthermore, I mean, you work in a busy ED. You can't be bedside with every EMS,
That's very
every
true.
EMS service, coming in. And I don't mean this to be in a derogatory nature of any kind, but the game of telephone can absolutely happen, right? So we tell, we give a bedside report to. I'm not picking on nurses. It's just it just happens.
That's who you're giving bedside report to, though. Right?
I give bedside report, and then maybe they're taking care of 20 patients. They heard every third word I said for whatever reason. They're having a bad day, and then you guys are conferring about this patient, and maybe it sounds completely like a complete BS case. And then, 20 minutes later, you look at that report and be like, oh, this changes everything.
Yeah.
And suddenly, like, I probably should.
Oh, it was a syncopal event, but the syncope was 20 minutes long.
And that happens. And then you would take that information and say, this was not a syncopal event. I just read your narrative that said it's lasted 20 minutes.
Yeah.
There's something bigger going on.
And to that point,
Maybe.
in my busy ER, it's very common that the patients coming in, they're going to a room, that nurse is busy in that pod, so another nurse takes the report.
It's covering,
and then so let's pick the worst example, nursing homes. You guys get a call, they go up, oh, not my patient, I don't know anything about them, this is what I was told. So then that that's the report you give that to nurse A. Then that nurse A is not really going to take care of the patient. Then nurse A gives that to nurse B. I go into the room to see the patient, and now I'm nurse B to me. And then that story is completely different. We've all were in kindergarten, first grade. We played the telephone game. We started on one side of the room, told a story, and by the time it got the other side, it was big birds out there laying eggs and shooting up heroin.
What kind of games of telephone were you playing? You had a very interesting childhood, sir.
This was med school.
This was last week.
Yeah.
Got it.
No, I think to your point, we have to be the eyes and ears for you in the field, because you can't be. Attaching pictures are so crucial in some sense. I mean, you want to see what the vehicle looked like. Here, doc, let me show you.
Oh, crap, that's bad.
Yeah. I wasn't kidding, or that's a lot worse than you made it sound. Yeah. Now I need to do a different evaluation. We might need imaging now, or there was a star in the windshield. Did you guys catch that? Because I see a star in the windshield. Was he secured?
Yep.
There's just so much you can take away. We talked a little bit earlier off camera on homeopathic medications, and we tend to in the field get around those and go right to the big names, but we can't do that always. I mean, take a picture of them, line them all up, take a picture of them, attach it to your report, say see attached.
Perfect, great, love it.
Yeah, this is recorded in 2022. Everybody has. Every device that you're charting on has a camera and a GPS on it, so we know where you were at when you took the picture.
Right.
But yeah, it's attaching those pictures are huge. And again, it doesn't just need to be of the MVC.
No.
It can be something as simple.
It could be the med list that the patient has from their prior visit or prior discharge. Or
I've used it for wounds.
Yeah.
Because if you're going downtown, you put the Cheeto gauze or the hemostatic gauze in. I don't want to see as soon as I get there. They yank all that stuff back out so they can see it. So I take a picture of it before we even bandage it. Sometimes it looks terrible on scene when you're like, oh no, hold on, I'm going to stop treating my patient to take this picture of this wound. People are looking at you weird, but it has a reason. Now I can get there and say, hey, here's exactly how it looks, doc. So before you go yanking everything off, use this to make your determination of what your next steps are.
I was at a residence once where a pediatric patient had received a laceration to the face, and they were with their grandparents. So I took a picture of the kid from the refrigerator to show to the physician to say, if you need to match wounds or what the kid looked like prior, this is probably your best bet. I mean, even something as weird as that.
Yeah.
That works, yeah. Especially if it's a funny looking wound, I'm going to have higher concern for abuse. And
exactly.
This is another tangent. All of us in this room are going to be mandatory reporters. So if we have any concern whatsoever, make that report. And social services, child protective services are going to go out, look at it, and then make a determination. And what was kind of missed from this standpoint, and even looking beyond child supporting the kids is also like human trafficking, which EMS is doing a big push for now, is having the wherewithal to just make that report. Because, yeah, it might be one minor report, but again, in the bigger context of things, like, oh, I've had 5 reports from the same address or regarding these people. Is there something going on here that we should look more into?
Even further, living conditions for
Yeah,
the elderly. Look in the
Reporting.
refrigerators. Look in the refrigerator. See if everything's within date. If you have a chance, see how are they living, or are there trip hazards that we can do on-scene education, and maybe take a picture of that and show the doc, because social work can work with that too.
Yeah, I had a great case where a squad came in, they picked the patient up, it was hoarding conditions, it was terrible. They took pictures of the room and everything, and I printed them out, and I even showed it to the admitting doc. I'm like, this is going to be in the EMS report, but here you can see right now what it was like, oh, that's bad.
Yeah, absolutely.
This is why they need to
might
cover
expedite
that.
things too.
Absolutely, yeah.
So do we have to worry about HIPAA, though? If I'm using this device to take a picture of the patient or the wound, the medical bottles, do we have to worry about HIPAA storing that picture on the device?
Well, John, do we have to worry about HIPAA?
How do you like me leading my own question? So
I thought that was our job, but no.
Just to make sure that the point didn't get missed. So because we are talking about health EMS in particular, it's really important that if you are going to attach a picture, is that you do it from inside of Mobile Touch. Go to the top right corner, hit those 3 dashes, hit attachment, take the picture from there. If you back out and use it as part of the native camera in the device, it is going to save to that camera roll. If you guys have a shared device that shares across, it could share to other people. So it's really important to make sure you use it from inside of Mobile Touch. That way it only gets saved in the chart and no one else is going to see it. So
said a different way, don't use the camera app.
There you go.
Yeah,
absolutely.
Don't use the camera app, but absolutely attach the picture.
And if you're having issues using the in-app camera through that, call you and talk to John about
Absolutely.
it.
We'll get it fixed.
Let's
We'll
fix
figure it out.
Because I've heard that also, that it's not working through there. You're probably not using the right browser, or maybe you need to update something, or call John.
Yeah, absolutely. Give us a call. We'll help you out.
Setting or something.
Yeah, 100%.
The other point about pictures I wanted to make was everybody's being sent home on medical equipment that we have never sent people home on before, right? Ventilators, pumps, wound vacs, all this stuff. If you don't know what it is and it's new to you, get a picture of it so you can show them, hey, this is what I was looking at, or here's the settings that were on the ventilator, or whatever.
Or the CPAP or BiPAP.
Or the CPAP or BiPAP
absolutely.
machine.
It's easy to go to our nursing homes and snap a picture of that, show it's respiratory when I get there. I mean, a lot of that's...
Oh, they will love you.
Yeah,
they do love
this
it. They
thing,
do.
right? It everything can't
Do you have
be-
settings for
Oh,
me?
that's the ventilator 3000. I love that model.
Bring that with you next time.
We need one
That's
here.
probably what it is.
We need one here. So, and then the other part of the documentation that we need to talk about, but I don't think anybody likes talking about is there's financial implications too. I mean, if
There is. You have to talk about it, though. I mean, if we don't get paid, we don't work.
well, I mean, if you want to replace your stuff, right? I mean, if you want, functioning equipment and, stuff gets broken, stuff gets lost, stuff gets stolen, you got to have the financial means to support our clinical motivations. There's a billing aspect to this, whether we like it or not.
Right, exactly. You're doing the job. Might as well get paid for the job. We can't control the socioeconomic policies that have put us under the Department of Transportation and made it to where we only get paid for transporting people. But this is where we live. This is how it works. Might as well get paid for the job we're doing.
It's one thing you're getting, for an agency that's getting tax money versus an agency that's, completely supported on that billing. I get that's two different ends of the spectrum there, but still.
But even if your tax money, you can go then and say, hey, look at all that we're doing. Correct. These are all the advanced procedures we're doing. This is why we need a new monitor. This is why we need video-assisted intubation. This is why we need this new CPAP device to help take better care. Because, hey, a third of our calls in respiratory distress, we're putting CPAP on, and that's bridging people to get to the hospital. That's stopping intubations. That's getting shorter stays and getting patients back to their homes, which is ultimately what the taxpayers want. Is they want better, high-quality care, and then to get them out of the hospital if they have to be hospitalized sooner. So it all ties back. But I want to go back to talk about the operations, too, as well as we do use that data for hospitals and stuff, but even like controlling what's in the med box or how many we have in the med box. If we notice that, we're exhausting a supply of a medication on runs, we need to then think, can we put more of that medication in the box for use? Do we have room for it? Oh, I see a lot of patients, or they're telling us we're going through multiple boxes just because we don't have enough of that medication in one box.
Like a break into a couple extra boxes.
Yeah, exactly. And then you're killing 2 boxes because I used up all of the bicarb in it, or whatever medication you're using. Now that box is TKO'd, and now I got to go open the 3rd box for my next round.
Oh, and by the way, now you're out of. Let's assume you had 2 boxes on your truck to begin with, which not everybody does.
But there's one that recently changed for the better. I mean, and you talk about putting more in it, was Narcan. Not that long ago, we didn't have as much Narcan as we do in our box now, but now we do. And that's because of what we're bringing back to you guys and your trending results and seeing that, my God, they need more Narcan.
Right. Ray's probably stressing when he's listening to this after the fact. Like, every time I was like, we should add stuff to the box. He's like, man, there's no room to put anything. I know. But yeah, we do jam that full. We're going to have an extra tier.
Still trying to get more in there.
Extra tier, put wheels on it, tow it behind the truck.
It's going to end up being like Mary Poppins' bag. You just keep grabbing stuff out of there.
But then we use that data to say, like, oh, we're not using this drug. That's another space.
Get
There's
rid of
something
that
else
one.
that can come
like
out
we
of
do
there,
that.
right?
We take this out. We'll put this in.
Or, like, I mean, we got rid of Lasix for reasons. I mean, because of our results that you were getting, we got rid of Lasix. So, or we obtained push-dose epi.
Yep.
Yeah, no, in lieu of dopamine.
In lieu of dopamine.
In lieu of epidrips. Yeah. All right, what do you want to dive on as far as the actual report itself?
The narrative.
Because that's where everyone goes.
Is that...
You want to go right to there?
We just want to go right to the narrative, or is...
So when you first pick up a report, what catches your eyes first? Where are we going?
I read the narrative.
You go to the narrative.
Age, sex, meds, narrative.
Blood thinners, narrative.
Meds.
And the narrative is huge. Kind of, I guess, to introduce this, I would say that in the medic class, and Scott knows because he teaches with me, it's a huge exercise for us that I push the narrative extremely hard. When we do a class on the narrative, we start off with a group leaves the classroom, a group is there, 2 students will reenact an incident, and that group will document on it. Then everybody leaves, the next group comes in and they read the documentation, and then the next group comes back and they try to reenact the encounter as it happened according to the report. And then the other group usually sits there who wrote the reports and laughs and says, this isn't close. Then, okay, we didn't do our job. We're writing a screenplay. We're writing a script. And if we can't reenact that script, then you didn't recall it correctly, or you need to tweak your documentation. And we run that until we get it almost pristine. And then you know your documentation's on point.
And you, John Cameron, have off camera and in previous discussions between you and me, you and I have brought up over documenting in the narrative may actually cause a situation where you're contradicting yourself elsewhere in the. I mean, we got to strike this happy balance, right? Of getting. Of being descriptive and making a useful tool for you and let's not just you as the emergency physician, but when that gets handed to the ICU,
Well, yeah, and everyone
to trauma service or whomever.
And we talked about that. Everyone reads that report. Like if it's a stroke, the stroke coordinator is reading it. If it's a sepsis, our sepsis coordinator is reading it. And we even use that information and vitals documented on that report to see do they meet certain criteria for care and when was that established. So that report's very important.
Yeah, and your point earlier about.
I just don't think you have to. The event log is there for a purpose.
Correct.
Right. So there is a huge amount of value in those event logs. So we can't run the data that we need to without using that event log. I can't read 325,000 narratives to figure out what meds we're giving. So
Well, you can. We don't want you to.
I do like to sleep every once in a while. So it's really important that you use the event log. And I want to really kind of differentiate the two and why it's important to not put everything in the narrative versus, everything in the event log. The narrative still is going to fill in a lot of detail, and we'll talk a little bit more about that in more detail. But in particular, in the event log, I really want to drill down on the fact that if you were to document an IV in your narrative, you're going to say, IV started, maybe you might remember to say the location, how many attempts, what size cannula, and what you may have flushed it with. If you document the IV in the event log, it's going to ask you what the location was, what size, how many attempts, so forth and so on. If you give a medication, it's further going to ask you, well, did they get better when you gave them that medication?
It's going to force some fields.
Intubation, it's going to drive you down that decision, not the decision-making process, but the other details about that intervention, treatment, medication, so far. So that's why it's really important to make sure that you are putting those details in the event log so that you get that full picture of each treatment. In the narrative, you can always reference those items so it flows well for the person who's reading it. But I don't think anyone ever needs to restate. Start at 18 gauge, left side.
Left AC.
Exactly.
Normal saline.
What you might want to add that I don't think is being added is, why did you start the IV?
Absolutely.
For what reason did you start the IV? And not so much it was an 18 gauge, left anticubitals, blood drawn. You put that in your event log, right? But why? Why did you start it, or why didn't you?
Right. Patient was showing dehydration. It looked appeared to be dehydrated, so I started IV, started whatever. Exactly. That reasoning for you, what you're doing, is hugely important.
That's what needs to be in the narrative. Absolutely.
And what generally happens also is when I'm QCing reports, I'll see in the narrative, I'll see vitals obtained, see attached, which is fine. But when I see attached, it was a 30-minute transport and one set of vitals were obtained. That's no good either. I mean, we should be doing vitals every 10 to 15 minutes, depending on the critical status, and we want to trend those results. And again, Dr. Hill's going to take that information, depending on what the patient's coming for, and use those trended results. So one set of pressures probably isn't adequate.
Yeah, most places institute at least 2, but again, 10, 15 minutes for a normal stable patient. But you have an unstable patient, it might be reasonable to do Q2 minute, 3 minute blood pressure checks. Because especially if you're getting push dose epi.
Why wouldn't you?
By the time you push the dose epi, you repeat it, you're going to probably need another push dose epi. So
a single set of vital signs is not a trend, and it's not.
It's archaic.
It's a snapshot of time. I mean, we know patients change, and what my vitals were sitting down in there are different than they are, sitting up here.
How would you catch something like Beck's triad or Cushing's triad without trending vitals? We're not doing our due diligence if we're not. So
yeah.
Right.
Going back to the event log, I'm with you. I think that you can reference it. You can say, hey, I started an IV, but let's say that you goofed and said, I started left in the narrative, but you documented it right.
Right.
So that's what you'd want to kind of avoid. And I'm a big proponent of, even my own documentation in the emergency department, is I will reference whatever you can see in the chart. So I might say put an IO in, but I don't say where it was done because it's documented elsewhere.
It's all the checkboxes.
Yeah, exactly. So I'll give a summary, or if I'm running a code, there's a code sheet that documents everything we did during that code. I will give a summary saying, hey, we gave 3 EPIs, we gave 2 bicarbs, see other documentation. What you're saying is see above, see that event log for what the details were of the event, but here's a summary of what we did.
I think people inherently go a little too overboard on the detail in that narrative unnecessarily, and bringing up the point. If you're going to read that narrative and you're reading it kind of as a summary of our care, do you care where the IVs generally?
No.
Where it's at or what size it is? Generally, no.
I don't. However, trauma does.
Yeah, it's like,
if trauma's
do you have access or not? Yes or no?
Correct.
Is what they need to take away from that story initially.
What you want to make sure
they want to know that particular thing, then they go to the event log to tease that out.
And then we should know as providers that if it's a case that might need MRI, we're going to want at least a 20 gauge angiocath AC or above. And if we say there's access given, I mean, hopefully they understand that. So
yeah, and I'm going to understand that, and it's going to be in your event log, right? Mm-hmm. And I'm a big proponent of not reinventing the wheel, but there are some things that are very important to go over. Cardiac arrest, you can just say that I gave epi, I gave bicarb, I gave calcium, whatever, I gave amiodarone. That's all you need to say. I can go, oh, you gave this. Oh, I can go back. Yep, you gave 300 milligrams of amiodarone. That was all appropriate.
Right.
What I don't think I like to see, though, and probably not you guys either, is in your narrative say, cardiac arrest, ACLS protocol followed.
I certainly hope so.
You certainly hope so.
Which version of the ACLS protocol were they following? Was that 2022?
Right,
1972?
So I don't think that's appropriate. I will tell you, I think a a lot of regularity in your in your narrative is pretty warranted. I know that a lot of physicians, I'm sure that most of the time you'll do the same
My
thing.
note is-
insert my normal physical.
Start note,
Exactly.
comma note,
And that kind of pre-fills a lot of it.
Oh,
And
yeah.
I do the exact same thing at work. I have a saved under notes on the iPad, my narrative.
Yep.
I copy, I paste it into charts, and then I go back where all my question marks are and I fill out that information.
Yep.
I know for a fact that every report I've written in the last 10 years is the same report tweaked to that patient.
And you can identify your reports too. Like, did you write
Instantly.
this? Nope, I did not write that because that is not how I do
That's
my
not mine.
documentation.
Instantly. So I don't QC my own reports. I let Dr. Garlisi do them. And when I get them back, I know right away who was on the squad because I can read the report. This was mine.
Yep.
I better go look at what he said.
But that's a nice, it's a nice form to have for your own flow, and you develop that over time. And a good way to do that is to review reports.
Oh, yeah.
Do QC with your med director, with your peers. I know that paramedics don't like to listen to each other about things, but you guys
How else are we going to learn?
Exactly. And I think that's
In the medic class yesterday, I stressed the fact that if we're not perfecting our craft, we're not doing due diligence, we're not doing justice to what we're doing.
Correct.
You should be sitting there and reading a Jim's magazine. You should be up to date on what medications are out there. I mean, at least have somewhat understanding of what they are, what an SSRI is, or what is.
Well, one of my ongoing frustrations, it's necessary the way we do things, but we have to teach to a curriculum, and that curriculum doesn't necessarily line up with current standard of care. So, and the good,
it's true in med school too.
right? Yeah, and the certainly this pivot as of recent with National Registry and the way we're doing labs and stuff. I'm actually pretty okay with it because the handcuffs have been taken off to where we can now talk more about hit the ground running with up-to-date current things rather than I have to I'm teaching antiquated stuff and then I'm basically teaching it two ways, right? It's like
This is what the book
I need you
says,
to know this for
but-
the book, right? This is how I want you to test.
This is how you take your
But
test.
this is what you're expected to do in the field, right? And that's I like that we're taking that path. I mean, it might be frustrating for some older instructors because, frankly, it was easy. It was just follow the check sheet, right? Boom, 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 rather than having to do think more about differential diagnosis and broadening essentially decision-making skills.
The critical thinking aspect.
The critical
of your job,
thinking
which
aspect,
is the
yeah.
most important part.
Absolutely is the most important part. All right,
is.
spinning back to narratives.
Yes. How do you do your narrative? We're talking about. I have my template. You have your
Everybody
template.
has a template, right?
How do you do that template?
So mine is event, chief complaint, assessment, treatment, transport, signature, exceptions. Every single time.
So you're not using the SOAP format?
No.
Are you sure that that's okay?
Is that okay?
Absolutely. I think that's. I had plenty of people
SOAP
say
format.
you must chart in SOAP, or you must use
Chart where you're comfortable
whatever.
charting as long as the
Absolutely.
information is there.
Absolutely,
And
that is huge.
I teach in the medic class my method, and if they don't like it, I also show them the SOAP method. I show them the E-chart method. I show them several methods.
Right.
I've seen QCing reports, books being written without any method. It's just here's a good description. I think that's a little overboard, but at the same time, you get the information across. Do I really care what the house smells like? Maybe if it smells like acorns or something. I mean, that could be pertinent information, but sometimes, like you said earlier, too much is too much, but there isn't one better method than another. Just get it right and make sure it's there.
And in my case, I just go chronologically from the time I got
Yep.
I got bedside.
and I think we're seeing more and more of that.
And that's how
I
do mine.
literally
But-
just here's what they were complaining of. Here's what my assessment revealed.
But I think
and if I didn't get to a conclusion to 2/3 the way through, then that's where my conclusion
Yeah,
is, right?
but it shows progress. Like, rechecked vital signs, hypotensive. Now I'm doing this intervention because of what I noticed.
Yeah, I will basically want you to put you or whomever is following and reading that, like, oh, this was the evolution, and that's just the way I choose to do it, and I've done that.
Yeah, but that's good to say, like, oh, they're fine, they're fine, they're fine, they're fine. Oh, now they're showing signs they're not fine. We did this intervention. They're continuing to decompensate.
Yeah.
And this is where
I'm trying to do things.
I'm trying to do
It's not
things.
Or
My interventions are not improving
Yeah.
improving, so we had to escalate. Now, are you typing these, or are you using Text to
I'm a
chat.
voice to texter.
It's I am not.
I'm a voice to texter.
All too often, I will be voice to texting and not go back and review what I wrote, and then all of a sudden I'm talking about a frog on a tree, and people
How's
are
that
looking
worked
at
out
me.
for you?
Not good, especially when your partner knows that you're voice to texting.
Yeah.
I'm not, but however, I'm not opposed to it. If you want to do a quick narrative, do it by all means, but review it before you submit it.
Absolutely.
So I was reading a chart even yesterday. It said patient moved to cat,
Yeah, exactly.
taken to moon. I'm like, what are you talking about?
Well, he jumped over the moon.
Into like on all my tablets at our shop, intubation always resolves as incubation. However, I can say methylprednisolone and it'll spell it out completely correctly. I'm like, why is this? Siri, you're messed up. But
It is not
Incarceration.
dragon dictation, right? It is Siri using
Yeah.
common language, and it's learning from you as you continue to use it. So depending on what browser you're using, if you're using Mobile Touch and Chrome, it's using the Chrome's.
But it's learning from the user, and if you have 18 users using it,
Right, exactly. It is not a perfect system. So the talk to text might work well for you if you're using your own device all the time, especially. But yeah, talk to text is a great feature to use, but you got to go back.
you got to go back. You got to go back. And you're basically choosing where do you spend your time. Do you spend your time on the front end or the back end editing it? It's personal preference, but nevertheless, and I guess what to put in there is the other thing we really need to kind of hammer on, because I certainly in my QA we had an employee who's a very, very nice paramedic and would write these amazingly descriptive narratives, and I would read it, and at the conclusion of the narrative I would have absolutely no idea what's going on. I knew
weather,
I knew the
the house.
I knew the astrological sign of the neighbor that was at the house, but I had absolutely no.
Taurus can be trusted.
But it's so use that. Is there value in scene setup? And and describing what's going on.
I think it's situational, and I would think that Dr. Hill would agree. But obviously, with a stroke patient, I would want to know the last known well. With a car wreck, I might want to know what speed and what the scene looked like when I got there. Was it raining? Was it wet? Was it snowing?
And this particular provider would go into this great detail of explaining the scene again very, very well.
But again, situational. If I'm suspectful of abuse or something, I would document the heck out of my scene. What I smelled, what I saw, what was there. Why do I suspect this?
So the what do we think as far as other pertinent things that really should be teased out in the narrative? We talked about expanding on the rationale for doing a procedure, right? So we use the IV example, but of course that would extrapolate out to every procedure.
Important to me, IVs are always important, but intubation, like how many attempts were there? Who attempted? The number of attempts might, and if you cause bleeding after that, did I cause trauma doing an intubation? So let's say 3 people attempted intubation, they all failed the endotracheal tube, end up with some type of supraglottic airway. And then I go to intubate, and it's not reported to me that there was trauma before, and I look in the airway, and I got a bloody mess. Yeah. Now, is this because that there's some other trauma, something else happened, or was this caused by us trying to provide care? That's very important. Yeah. And documenting, why am I intubating the patient? Is it for ventilation? Is it oxygenation? Is it just I need to stabilize the airway because they don't have control of the airway and I need to take control?
Inevitable loss. Yeah.
Yep, exactly. Mm-hmm. And even projected course, they're going down, they're decompensating in front of me. There's going to be an obvious surgical patient. Putting that ET tube in is totally appropriate, and you want to do it when the patient's healthier, because as soon as you go in to take that airway, you're already putting them at high risk to getting crump after that.
One of the nicest additions to our protocol update last was that somebody added the words imminent loss of airway, and that's where we're now using that, and I think that's way better suited for what we need.